So, my dear students, welcome to the series on bone marrow aspiration. The topic I had chosen for the day is myelofibrosis. Obviously, you people know the meaning of the word fibrosis. The myelofibrosis term was first described by Gustav Hug, and it was also introduced by another person called as Herbert Asman. As a result of which both these names are joined together, Hugh-Asman disease, or it is purely called the Asman's disease, or probably even the Hughes disease. So that is myelofibrosis. Initially, they thought it is more of an osteosclerosis, and it was published thus in the year 1907, courtesy Journal of Clinical Diagnostic Research. Look at this one. There are many slender fibrils of reticulin that I could say. Always what will happen? These will join together, mature, lay down the matrix and get converted to the collagen fibers. So all the three we people can see. That is, there can be two stages. Some people say it is a misnomer. Some people say it is definite too. Anyway, let us go by what is on the screen. There are two stages. One is the prefibrotic and the second one is fibrotic. In the prefibrotic, there is no fibrosis. The bone marrow is hypercellular, minimal reticulin, and there will be an increased number of megakaryocytes and granulocytes. Whereas in the fibrotic stage, as the name denotes, you find that there will be a fibrosis setting in, a decrease in the cells in the bone marrow. They will not be having enough space to mature, as a result of which they will come out into the peripheral blood in an immature form. That is called as a leukoerythroblastic reaction. The peripheral blood picture I shall be showing. Age more than 50 to 60 years. Male and female are equally affected. So, this is what I had earlier told you. And the treatment ultimately will be only a stem cell transplantation. The features are thus. There can be a hepatosplenomegaly because there will be an extramedullary hematopoiesis. Lassitude and anemia, obviously because there is no active erythropoiesis possible. Bone pain, again the bone marrow is attempting to expand. Extramedullary hematopoiesis will be seen. Gout and increase in the uric acid will also be seen. Leukoerythroblastic picture. Viscosity of the blood can increase in some cases. And rarely you can get cutaneous nodules called as cutaneous myelofibrosis. So these are the clinical features, the substance that is being deposited, and what is the treatment. Primary myelofibrosis. It is a type of, again, myeloproliferative disorder. It can be associated with fibrosis. But more important will be there are some mutated cells, and it is a somatic mutation in which there can be a defect in JAK2, Janus kinase, CALR, or MPL genes. So what happens is, just like your other disease, the sickle cell anemia, you find that valine-2 phenylalanine happens at 617 position. So it is called as V617F substitution. This is a peripheral blood picture of a patient with myelofibrosis. Let us see what we can observe. Most of these elliptocytes, I think I can make out. And if I look very carefully, there are some teardrop cells. They won't be hypochromic as in the case of iron deficiency anemia. At the same time, there can be some, look at this teardrop cell again. There can be some fragmented cells or schistocytes or helmet cells which are being seen. So there is another fragmented cell over here. This is what is seen. A giant platelet is also present. All these are indicative of something is being wrong in the bone marrow. There are two stages, as I had mentioned, the prefibrotic. WHO has given the major and the minor criteria. I would like you people to kindly go through. So in this one, there is megakaryocytic proliferation and ATPR without reticulin fibrosis. So it does not meet the criteria for other myeloid neoplasms, a lymphoma or a myeloid leukemia, so on. There can be the presence of any of these mutations, JAK2, CALR, or MPL. Is it clear? And there is no other cause which can cause a reactive bone marrow fibrosis. The minor criteria, at least one will have to be present here. All the three are needed. So in this one, and another catch is it has to be present in 2 consecutive examinations. Anemia without any comorbid condition, leukocytosis, splenomegaly, and LDH increase. So these are the things. At least one should be present in 2 consecutive examinations. Next is the primary myelofibrosis. After which, you find that there can again be the major criteria. It is almost the same, except that here you find that the grades of fibrosis or collagen deposition will be grade 2 or grade 3. There it is grade 1. So the other features are almost the same. And here again, I find that there will be anemia, leukocytosis, splenomegaly, and there can be a leukoerythroblastosis. At least one of these features should be present. So this is the minor criteria for primary myelofibrosis. Regarding the pathogenesis, it is not a theory class that I am taking, but still for the sake of it, whatever we had touched upon, let us see if we can see it in this picture. MPL receptor. So there can be an abnormality in this. Mutation in the CALR. So this can be the JAK2, JAK1 and JAK2. There can be abnormalities in these regions. So there is a nuclear transcription which can produce various growth factors such as the vascular endothelial, fibroblast growth factor, platelet derived, etc. And these will be leading on to angiogenesis, fibrosis of the marrow, and osteosclerosis. So also you find that there is a progressive destruction of the megakaryocytes. So this is a good picture. I would like you people to have it in mind. This is again a fantastic diagram. Initially, you find that there is a clustering of the megakaryocytes. They do not appear normal. They are highly lobulated. I find that there is a hypercellularity in the marrow. At the same time, I will not fail to appreciate the lines that are going in between the cells, which means there is a fibrosis in the background of cellularity. So dysplastic cells are there, irregular nuclei, and one thing that we should differentiate will be from primary essential thrombocythemia, not cytopenia, cythemia. So there is an increase in megakaryocytes. Whereas in the later stages, it becomes hypocellular and it is replaced by fibrosis. Bone marrow osteosclerosis is there. Irregular bony trabeculae are there predominantly. And a dry tap will be very, very common. Courtesy for this particular reference, a superb set of pictures that he had given to us. Authors, Kasib and David. To be continued.